Great to see all these wonderful familiar faces. So I am going to share my screen, tell you, are we getting everything okay? You guys able to see that? All right.
Looks excellent. Thanks,
Awesome.
thanks.
Sure. So what we're going to talk a little bit today about is why environment matters in public health research and it's often missed. And so it's something we really want to talk about and how we can engage our citizen scientists in helping us collect this data to really inform how to improve public health. And what we're going to do is Jordan and I are going to present kind of two different spectrums of using strategies to engage communities in public health improvement. Jordan is going to present at the end of this, and he's going to talk about using it in the earlier phases of research when you identify, it's essentially the needs assessment. What does this community need to improve? Using the physical environment to help inform, like, how can we make this community better? What are some things that we can do to improve health? And he's going to talk about the strategies that he used to do that phase of it. I'm going to talk about a little bit different phase where we have an effective strategy. We have something that really works and is safe and effective, but we don't reach all the populations that we want to reach. And we're trying to find strategies to engage with the community to get those effective interventions out into the community. And so we'll present kind of different perspectives. You might be falling in either one of those. And so hopefully this will help you kind of find some strategies to use along the way. So this statement, context matters. I'm sure this is not a surprise to anyone. Context matters. We know that context really has a big influence on how programs are implemented, why they're different in different environments. And I really like this example that Dr. Lambden has here from some work with certain service programs. And so today I'm going to be talking a little bit about take-home naloxone programs. And those of you who aren't familiar with take-home naloxone, naloxone is an opioid antagonist medication. So essentially, if someone is having an opioid overdose, you can give them naloxone and it reverses the effects. And so bystanders, people that are using drugs with other people, are the best people to have access to that medication. It is highly effective. It's very safe. And so there's been a lot of programs trying to get this out to people in communities. All 50 states have standing orders and allow people to have access to it. And that's how syringe service programs are able to distribute this medication to people in communities. And so what Dr. Lambden was looking at was syringe service programs, let's look at syringe service programs throughout the state and identify some contextual factors that are contributing to the distribution of naloxone in these communities. And surprisingly, what he found was that it wasn't overdose mortality rates, which is really the best measure we have of a community that needs naloxone. That was not predictive of naloxone distribution. Instead, it was community support was one of the factors. So things like this community supported a syringe service program in here, we had higher rates of distribution. So this specific contextual factor had a big part of, what they were able to do, how they were able to implement this program, and was really key to naloxone distribution. So we know context matters, but there's all these people that have an influence over how something gets implemented, what is done. I like this article, this 7 Ps framework that Kincannon and colleagues identified. It really highlights those 7 people, these key players that are involved in implementing a program. And it talks about, the patients and the public, but it's also the payers. It's also the people that are buying the service. It's also the policymakers that are influencing how it's done. It's all of these groups of people. And interestingly, I liked the product makers on this too. Sometimes we can't do certain things because the products don't allow us to do what we want to do. So it limits some of what we can do. So I like this, but I think there's an 8th P. I think the 8th P is for place. And I like this picture. I found this from the Kentucky's University Public Radio website. They had, a picture of this exciting new naloxone vending machine program in Kentucky. And I was looking at this picture and I'm thinking, okay, if I'm someone who uses drugs, am I going to use this resource? Looking at this picture, maybe. With this police officer standing next to it, maybe I won't. And so the environment, the physical environment where something is, who's in that environment is really going to have a big factor on who uses services and how we access them. I think, Jordan will talk a little bit about this as well too. And it's not just the who uses, it's not necessarily just where it is, it's how we get there, the access to resources as well. And so this is really an example of how walking environments can impact physical activity, but it's also transportation mobility, providing safe access to public transit stops. If this walkway wasn't here, you might not be able to get to that building across the street. So maybe somebody isn't going to be able to access those resources and use them. So who we're reaching with our services, who's accessing them, the physical environment has a big impact on those factors. And so, Nilsson and colleagues wrote this article looking at contextual factors in implementation science frameworks. And they identified, kind of 12 factors, things like, patient's perspective. They talked about financial resources, readiness to change, some of these factors that influence implementation science. And physical environment was one of them, but it was only included in 2 frameworks. So really something that is a key part of context, but isn't necessarily evaluated and considered as much in implementation science as it maybe should be. So when we're thinking about environmental factors that to consider in our program implementation, there's really 2 levels to think about. There's the macro level, which is our community layout and land use. This is like access to public transportation. And it's really well suited to help us identify what are these key themes in the environment we need to think about when we're placing these programs. And then there's the micro level features, and this gets at some of those context specific things. So these are observable in a setting. Do we have good lighting? Are there cameras? And we like to think about these in 3 categories. There's the natural environment. So there's things like vegetation and weather. I'm doing my work in Colorado, and I have 3 sites. One's in Breckenridge, one's in Denver, and one's in Pueblo. That is 3 completely different weather environments in all 3 of those locations. Weather matters and has a big impact on what we do or how we access resources. Social is also key. Who are the people in this environment? What's the culture like in this environment? And then there's also the built environment, the man-made features, things like benches and buildings. If you're doing something for a population who, has mobility issues and there's no bench to sit down, or it's an older population, these could be factors that really influence what people are willing to do or where they're willing to go. Slides just got stuck for a second here. All right. So I'm going to walk you through my case example, which is harm reduction vending machines. So this is an example of kind of trying to implement something that we know is effective and reach more people through this program. And so Jordan will jump into his kind of needs assessment, earlier assessment, and when we're done talking about this case example. So as I talked about, take-home naloxone is this really great strategy to increase access to overdose prevention medication or overdose reversal medication. And so naloxone, the problem with naloxone is that it's not distributed well, basically. We're not getting it to our high-risk populations, and this is growing. There's an expansion of naloxone. We're getting better at doing this, but there's still low rates of distribution. And pharmacy data shows that we're not really doing a great job getting it out. And there's also disparities in who's getting naloxone. So there's people of color, low socioeconomic communities, rural communities are less likely to have access to naloxone. Geographic regions also have differences. Certain parts of the country have more access than other parts of the country do. So there's these disparities in who is getting access to naloxone. And as we see these growing rates of opioid overdose, fentanyl in almost every kind of drug that's being obtained on the street, there's this huge national push to increase access to naloxone. And so communities are trying to figure out ways, how do we get naloxone out? There's naloxone saturation plans. We're trying to get out in the communities, get as much out there as possible. And so one strategy communities are starting to use is harm reduction vending machines. Harm reduction vending machines are exactly like they sound. It's a vending machine, like a snack machine, a soda machine. You go in, you push the button, you get access to it. A lot of communities are now using what we're calling kiosks. And a kiosk is, this is going to age me talking about this, but newspaper machines, when you go up and you put a quarter in and you open it up and you pull out a newspaper, they're converting those, since they were being used less for newspapers. They're starting to convert those for naloxone. They're putting naloxone in it and people are putting it in their communities. And so they're using these machines that they can put in all these different locations for access to naloxone. And what we know about these machines, they've been around for almost 40 years in Europe. So a long time they've been around there, and they were used for syringe services. So they were used to, where patients could come up and get certain services in different locations. And what they found in Europe is that they actually reached these hard to reach populations. So they tended to be younger. They were people that hadn't been using for drugs as long. They were less engaged with treatment services. So it was people that were like, I know I need to get this, but I'm not really engaged with the health system yet. And it's a way to access these important resources. It also increased geographic availability. So people in rural communities that didn't have as much access to these services were able to get it, and temporal availability, 24 hours a day, made it great. So we've started doing that in the United States, not for long, but we have started. So in 2017, we had our first implementation in the continental US. TRACK-B Exchange in Nevada implemented the first one, and they've done some evaluations with it, and it has been associated with a decrease in opioid overdose deaths due to the naloxone in the machines. And so we know naloxone's effective. We know these strategies can reach hard to reach populations. And so I talked to some young adults a few years ago to say, okay, would you use this? Is this something, here in the US we can implement and would be something we would consider? And I asked them, what are your barriers to naloxone? Why aren't you getting that now? And what could help you? What would this strategy work, and how should we implement this? And what they told us was, we're not getting naloxone because, particularly when I was early in drug use, it was privacy. I didn't want anyone to know I was using drugs. I didn't want to go get anything that would associate with me with drug use in any way. So that privacy was really important. Convenience was also really important. If I'm seeing my doctor, he writes a prescription for me and I have to go all the way over to the pharmacy, that's going to be a barrier for me to access those. And some of them talked about, particularly earlier when they were living in, some of them talked about rural communities where they didn't know about it. They didn't know naloxone was a thing until they started going to the harm reduction services or until they started receiving other services. And then they were made aware of it and were like, oh yeah, this is great. We should have this. The young adults were very supportive of vending machines, and they talked about, I would use this, but you really have to think about the location. That was kind of a key thing that came up. And they talked about both macro and micro level features. They talked about easy access, have it close by bus stops. Let's have it by the drug access points. In Denver, one of our common places where people buy drugs and use drugs is at City Park. So they talked about, put one in City Park. There should be one right there where we're buying our drugs, have it easy access, have it available 24 hours a day. We use drugs at night. That's when we want it available, and it should be outside. Those were some key things they talked about. And then they also talked about kind of those specifics of, I don't want law enforcement walking by all the time when I'm there. I want safety. We had female respondents talking about making sure there's good lighting so they feel safe if they're using it. Those were all features that were kind of highlighted by our participants. So what's happening? We're expanding. Tons of places are implementing these programs now. They've really grown. COVID kind of initiated a big push for these. And what we found, the issue is people are doing what's feasible. They've got funding, they're trying to figure out, and they're just doing what they can do. So TRACK-B Exchange, that first group that implemented it, they're like, okay, look, we can put this in our building. That's how we can get it by this first time. This is how we're going to do it. But it was during those business hours. And so, when I talked to the director, she's like, with this particular one, we're reaching the population that's using our services already. We're already providing naloxone. It's a new resource for our group, but we're not reaching new people. A lot of police departments are implementing these, which is great. It's a new population to potentially reach, but they are noting that, there's certain limitations on who will be using this program. So Pat Bradley is a reporter from Northeast Public Radio, and he noted in his report that the police chief in Saranac Lake, New York, when they implemented a program, noticed some hesitation to come into the lobby and use the machine, and he attributed that to stigma. So there is, where it is really going to impact who you're targeting, and there's lots of different locations that it can be put in, lots of different people to reach out to, but who are you targeting and where do you want it based on that population is really, really key. So that's what came to my grant that I'm working on right now. And I'm going to tell you a little bit about the methods here. So this is called Vendy. It's a vending machine naloxone distribution in your community. And what I'm doing is implementing a naloxone vending machine in 3 communities. And I'm working, it's a pilot test, and we're working with 3 different types of organizations to try this strategy across different organization types. So a health system, a harm reduction agency, and a public health department. We're looking at how this works in those kind of 3 different environments. And we will use an iterative process that engages community members in this discussion as we build this program. So implementation science, those of you who know much about implementation science, we have, and Nicole, you might know this, 152, I think it's more than that. That was at last count, some insane number of frameworks. And the common saying is implementation science frameworks are like a toothbrush. Everyone has one and nobody wants to use anyone else's. Well, PRISM is mine. So this is my outline of my concept model for this project. And I use PRISM. PRISM is, for those of you not familiar with it, it's an expansion of the REAIM framework you may be more familiar with. And what PRISM does is it highlights those contextual factors that influence a program, how it's implemented and how it's accepted, those essential outcomes that indicate the value of a program. And so it looks at the patient perspective, it looks at the organization's perspective and characteristics, it looks at the things like policy and also factors such as your implementation and sustainability infrastructure. And so when I put this together, I was looking at those barriers we had identified, and we know that convenience and privacy are important. Okay, so we're going to do a vending machine. We're going to make this convenient and we're going to make it private, but the where is important. And so incorporating those built environment evaluations is a critical component. And then we also have all these different layers of people that have to approve this program and a large group of partners in this. So we have our community partners, but we also have procurement and legal and all of these people within our organization that have to give the sign off on where it's located, who we're partnering with, what's all those different steps in the process. And so we need to navigate that multi-level, feasibility of it. There's also kind of a layer of iteration that's required. And so we built this concept model to say, okay, we're going to do this take-home naloxone program through vending machines with overdose education. But we're going to do this, we're going to build this using a strategy that is iterative. It incorporates the community's input and engagement and has built-in social environment components into it. We're going to evaluate that and make sure we incorporate that. So we're actually reaching new people with this program. So, you're trying to ensure we engage people and are reaching new people in the program. Well, nobody does that better when you're looking at environment than Dr. Abby King at Stanford. And so I'm lucky enough to collaborate with Dr. King on this project. And so I want to talk a little bit about her methodology and how we incorporated that into this program. But so our voice methodology is really about active involvement of citizen scientists used to improve the health of communities. And I'm not a historian on Our Voice, so I won't pretend to be, but I will point you to the link and include that in the resources. Please go to her website. She has some great resources in there, tons of information about their program. And I strongly encourage you to look at that if you're interested in this methodology. But it really started as a way to capitalize on technology to support people in the community, citizen scientists, to be the change agents. It allowed them a tool to collect data and say, here, we have this data, this is what we want to change, and we want to improve in our community. And it started with physical activity, but has really advanced beyond that. And I'll talk a little bit about that in a minute. So here's the essential methodology with Our Voice. It's a 4-step process. And in the discover step, it starts by figuring out what about your community impacts healthy living. And so you go on a walking audit. You use the Discovery Tool app, and I'll show you a picture of that in a minute. But you walk in your community, you take photos, you record your thoughts, and you say, what can I improve in this community? And then in your second step, you come together. These citizen scientists come together and they talk about it and they say, okay, what's the thing we can do? What can we change in our community? And then they advocate for those local changes. And ultimately they change their community for the better, and they can measure, they can evaluate outcomes, track activities, celebrate successes, all of those things. So this is an example of that discovery tool. This is the one for my project where we ask people to take photos of things around you that would impact using naloxone vending machines, and then they can record their thoughts and they can say whether this is good or bad for the community. So it tracks geospatial data, it has photo voice, it has comments, so it really brings that voice in from the community perspective with this data tool that they're using. So the Our Voice work is being used all over the world. You can see on this map just all of the locations that have been using Our Voice. It's spread, everywhere and across many topics. I also want to highlight that it really started with, improving walkability and physical activity in your community, but it's done across many things. I'm using it for substance use work and identifying stuff to address, to increase access to services and safety and violence prevention. It's used across the spectrum for many different topics and all across the world, and is having this large impact at multiple levels through individual, social and community, built environment, and policy. And so I stole all of these pictures from Dr. King's website at Stanford. So it goes into great detail on it. And I thought her visuals were much better than what I could recreate for it. So it's a lovely way to see how well the Our Voice methodology has worked. But one of the challenges I faced is that I'm using this a little bit different than how it's normally used. So we're trying to use this as a way to implement a new program. So it's not really identifying what needs to be changed in this community, but more where and how. And so we had to adapt it a little bit. And the other implementation consideration is that, we have these multi-layers of people involved in this. We have organization that we need to consider. For example, one of my sites said, we won't get this approved if it's outside. So we need to think about inside locations. I had, another site that was thinking about, risk aversion. We don't want this in our local paper. So how can we build this in a way that, we get it out there, we get it to as many people as we can. We don't draw too much attention to anything negative that we're doing. We don't want vandalism. We don't want kind of these negative repercussions of this. And so how do we do it in a way that can meet those needs of our organization as well? Because they're the ones that are having to sustain and implement this. We also have policies, pharmacy regulations, laws, standing orders, all of those things play into how something is implemented within a program. So to bring these ideas together, we really wanted something that would incorporate this iterative process. And so we looked to human-centered design. So human-centered design is really started in systems engineering. And those of you that do work in building apps or computer programming, you're probably familiar with this strategy. And it's really kind of designed around computer-based programs, but is very applicable in other situations too, because the concept is really about iterating and working with your multiple stakeholders, going back and forth and figuring out solutions to these problems. You prototype it, you pilot test it, you evaluate it. You kind of go through these steps in the process to engage and figure out what's the best solution under the circumstances that we have here across all of our stakeholders, with the ultimate goal of engaging with that user, the person that's going to be using it at the end. It has to work for them. And so, I cited Dr. McGuire's work in 2001. He wrote a really good paper on this in 2000. It's an oldie, but a goodie. And he was really talking about those key steps, the key principles in user-centered design. And it was that, engagement, active involvement of the user to ensure that it's functional, it works for them, it's usable, that we're not asking too much of them. The system's not doing nearly as much as it could for them. So it's just really understanding kind of that back and forth process. And so that brought together this whole concept where I'm bringing Our Voice methodology and this human-centered design pieces together. And so I'm calling this Easy Ops, but it's essentially the strategy that was used to implement this program. And so we start by investigate and discuss. So this is really about figuring out with both the organization and with the end users what is ideal. So we meet with the organization and you say, okay, where can this be? What is reasonable in terms of locations? And then the red boxes here go to our population. So this is our end users. So in this case, it's people who use opioids. And you walk it and you say, tell me where this should be. Let's walk these locations. Let's get your feedback. We go back to the organization and we say, okay, what they selected, is this feasible? Do we have more questions we need to ask? It's really this back and forth process between the user and the organization. And then they all get together. Once we've kind of gone back and forth and figured out, okay, these are the requirements that we have to do to be feasible. This is what's desired. let's all get together and let's prototype something and let's figure out, okay, this is what we're going to do. In human-centered design, this is called building your minimum viable product. This is the thing that we can start with. Let's try it. And then the next stage of our research, and we haven't gotten to this, so we won't be talking about these stages, but we will. We are getting to kind of the pilot test where we're going to check it out. We're going to look with our end users. We're going to look with our organization. We're going to measure these outcomes after a few months and see what's working, what's not working. We can refine, we can adapt, and then we can get it in a place where we feel good about it and evaluate it over a longer period of time. So I'm going to provide a little more detail specifically on the walking audits because I really want to focus on the environmental piece here. But we are this investigate and discuss, this early stage. So this is kind of the discover stage from the Our Voice methodology. We started with the organization. We said, where are we able to implement this program? And now we're going to the end users. But we want to do this at both the macro and the micro level. So we say, okay, here's a map of where we can do this. You tell us what's your 5 best and 5 worst locations, and you tell us why. And then we're going to walk it. We're going to walk those locations and we're going to take photos of things around you that you think would impact using naloxone vending machines. And we probe them, we ask them to think about those natural, the social, and the built environment components while they're doing that. And then we talk about it, we bring them back and we discuss it and we say, okay, is this feasible? And now with this population, you know, in Our Voice methodology, you bring your citizen scientists back together and they decide, they talk about it and they go back and forth. With this cohort, these are people that don't necessarily want to be identified as someone who uses opioids, and having one-on-one interviews is more comfortable. And so bringing everybody back together becomes a real challenge and is maybe not the ideal scenario. So they feel they can get their voice this way. We can use the photos, we can use their quotes, and we can express their what they're feeling. But then we also, at the end of the interview, anyone who's interested can now come back to that implementation team meeting and give their input when we're kind of finalizing those prototype decisions and bring their input. If they're willing to, you know, acknowledge that they use opioids and actually come to the meeting and be someone with lived experience at the table. And we have had one person at our first site offering to do that. So we have some support from that group. So then we go back to the organization and we say, okay, here's some stuff we learned. And they say, oh, well, we're not going to be able to do it quite that way. Can you ask about this? Or can you go back? So it's really a back and forth kind of process where we do this stage, but we don't do a sample of them and then we're done. We do a few, we bring it to our group and say, here's what we're learning. What do you think? And then we go back and we refine and we revise and we ask different questions and we move it forward. So this iterative process is really the key to the strategy. And then again, we bring our group together and we build our minimum viable product. We build what we're going to do. We balance the end user desires and the feasibility. So you've got these two perspectives and you need to balance those. We're not going to use it if it's not outside, or we're not going to, you know, they bring their perspective forward, but then say, well, it's not feasible to do it in this way. Can we consider this way and use that implementation, that combination of those two desires to figure out the best solution in this specific context? And then we pilot test it. And what we do in that pilot test is actually bring back that environmental evaluation. So after a few months, we bring people, now we have a real thing. We have it in action. So we bring users and non-users to come look at it and they're going to walk. They're going to do walking audits of this and they're going to tell us what about this is working, what's not working. And they can give us that feedback so we can potentially improve or adapt the program as necessary. And then after we kind of refine and adapt, we'll be able to evaluate over this 6-month period. So we have done this in a federally qualified health center in Colorado. So as I said, we're doing it at a harm reduction agency and a public health department. And we are pretty far along in both of those locations, but we have more data at our health center. So that's what I'm going to present to you today. So we recruited citizen scientists that were at least 18 years of age and have used opioids in the last year. And we used flyers in our clinic. Our providers sent them out. We have a community advisory meeting with people with lived experience, and we recruited through that group. It was kind of a snowball sampling where people were recruiting their friends as well. They'd see the flyers and then they'd participate and say, oh, can I invite my friend? And there would be some additional snowball sampling as well. It was a 2-hour interview, in-person interview, and then our organization team that was also meeting, we had separate meetings. This included our organization leaders who were approving the program implementation, as well as our program managers that were overseeing implementation. And then our implementation team will be bringing those two together, a citizen scientist as well as our organization team, to talk about, this is the prototype we're going to use and build. So I'm going to present these results in 2 ways. First, I'm going to talk about the value of each step we had with our citizen scientists. So you may think, like, just let them walk around and tell you which place to go. This should be a one-step process, but there really is some value in the macro level, and the micro level, and that discussion at the end. They all 3 provided really unique data that was helpful in the process. After I give you these results, I'm going to talk about that iterative process and how kind of that back and forth really is leading to some really great outcomes. So these were our citizen scientists. We did this with 7 participants so far, and we have, on average, they were 42 years of age. They were 30 to 55. 100% of them had witnessed or experienced an opioid overdose. The one thing I do want to know, we had a good chunk of people who were non-white that were reported Black and Neji, but we have a large Hispanic population, a Latinx population in our community, and they were not well represented in this cohort. So that is one group that we are trying to outreach to and make sure that we capture in our next round of these that we do. So we have quite a few of our cohort was below the 200% poverty line as well. So I'm going to walk you through the steps, the data, some of the data we got with our citizen scientist, Bob. So I'm going to call him Bob. So Bob was walking. Our first job was to sit at the desk and look at a map and circle the best and worst locations. And so this is just kind of a chunk of the map that he was looking at. And I want to highlight a few things. On the far right, you'll see the word Broadway on the side. That is a very busy street, but it has a bus stop on it that has a lot of drug use occurs at that location. And so it's a busy street, but it's a lot of action there. And it's a good transit stop for buses, for drivers, for cabs, for all kinds of things. And so it's a busy street. The other thing to notice is over where you see 5 on the far left, there's a K there. That particular clinic is where the substance use services are provided. That's where the methadone clinic is. There's a little alcove in there, and you'll see a picture of that in a minute, but that's kind of where people provide substance use services on campus. That street right next to it, Bannock Street, is one of the busier ones. It's kind of a main thoroughfare through campus. So there's a couple bus stops. There's a lot of action on that street, and it goes directly into the emergency department. And so Bob identified this kind of offshoot location. And this is where we are, we're expanding services, and our community advisory group is our CAM is providing some knowledge information for our substance use population. There's an education center that's going to be built there. I believe it's that. I should ask, I know Josh is on the call. He can correct me on that piece, but they're building a cool program there for people to use. And so I was explaining that as we were talking about the map, that this will be here soon, and this is in this building. And so he's like, yes, that's perfect. It's right by Broadway. It's convenient. It's easy access. It's private. People won't see you over there. You're off the main campus. This is my number 1 location. And then number 5 for him was, in that location where the substance use services are provided. So, across all 7 of our interviews, that first step really identified those key themes. It was consistent with what we had heard before, but privacy and convenience were really important. And these are some really great quotes from participants that highlighted that. This person said, "For me personally, I like to keep a low profile about my addiction. I wouldn't really want it to be an obtrusive place because I might be embarrassed about going up to get it. I don't know, it's a little bit of stigma with it." And so it's really, it's not the naloxone. It's, I just feel stigma. And if people see me getting naloxone, they're going to assume I use drugs, and I don't want anyone to know I'm using drugs. It's kind of that concept. The convenience is, they were talking about a location that was near just a lot of access points. And they were saying, there's, whether you're walking, you're on the bus or driving, it's convenient, it's easy because it's never congested or really packed that way. It's a little offshoot, but it's easy to get to. And that convenience is important. So this is the walk we went on. So we're walking to Bob's number 1 location, and this is what he encountered. And this is the picture he took. After the end of this walk, the number one location, his top number one location at this faraway location, and his number 5, which was the substance use service building, switched. Number 1 was now the substance use services, and number 5 was this location. And he said, you know, when you look at it from a convenience perspective, I think it would be inconvenient because there's so much traffic and this construction makes it even worse. So it's hard to get over there. So he, you know, this specific micro level feature, this was in the environment in this location at this time. And he's like, yeah, actually I'm on this street now and it's busy. And this is not where I would want it to be. This is a little harder than I thought. Now that I'm walking it, now that I'm here, I see this different perspective. So what we learned from our 7 participants was that, you know, from these key themes that we asked about, the social environment, privacy wasn't about the quantity. It wasn't the foot traffic, but the type of people. So they didn't want security there. They wanted other people who use drugs. That was comfortable, but not if there was a lot of other people around or security around. The natural environment, they really liked the outdoor landscaping. It was appealing, it offered cover, and the built environment provided that convenience and privacy. They liked that next to bus stops, supported convenience, lighting, kind of had that security piece. There's cameras all over campus, and so the cameras weren't really a deterrent for people. They were used to seeing them on campus, but they did note that if it's on the machine, that could potentially be a deterrent for use. So this was when I talked to Bob about it, I said, okay, what can I take back to my group and tell them? And this was the picture he told me to use. And he said, you know, there are people like me here. You know, Bob's quote is much better than anything I could, you know, than my description and trying to, you know, show people these were the top 5, these were the bottom 5. My description of this was not nearly as good as Bob's quote in his picture. And it really gave voice to what this community wanted in this location. So, you know, we have these steps, the importance of these steps in the process. And now I want to talk about the importance of the iterative process and how not just kind of, we did this step, then we did this step, and then we did this step. Actually going back and forth with these groups was really key. And so we started with the organization team. And they really, you know, when we first talked about this, they're like, you know, ED is going to be the best place, 24 hours a day, easily accessible, lots of foot traffic. Let's do it there. Maybe the outpatient clinic, pharmacy, these are good locations, but we're not going to give any restrictions. We just want to know what people think. So just show them the whole campus map. They can tell us where they want. We did 2 interviews and only identified outdoor locations. They didn't even want to walk in buildings. They're like, no, I don't want it in there. I wouldn't use it in there. And so we started to think about this and we're like, oof, is this going to be feasible? You know, can we do outdoor? Is outdoor going to be feasible? Or do we, you know, we were really thinking indoor is where it would end up being, but now outdoor is really an option. Is this feasible? And so we talked to the organization team about it and they were surprised by the initial results. And they were like, you know, confidentiality and privacy seem to be more of a 5 to 10-year-old concern. And I'm surprised it's not in the main hospital. I've seen other locations. They try to find places with high foot traffic. I would think the hospital would be a key place, you know. But then when we really presented we used the voice of our participants and we presented those results and they really came to understand the importance of privacy. We're talking about, I would say stigma isn't around naloxone, it's around being a user. I think the idea of having it close to the methadone clinic makes sense. This is a safe place where people know they can get support. They do hang out there, but it's mostly that population. So we did, you know, we talked about, yeah, okay, I get it. I get why they're saying this, but we do have some feasibility concerns. We want to make sure it's not so far removed that we can't monitor it in any way and someone vandalizes it and we don't even see it. You know, there's those feasibility concerns. And so we need to be kind of within the scope of what's feasible. So our next step was to go back. Let's see if security cameras will be sufficient, if we can actually have it outside, if we'll be able to get by with that. But let's also ask if it has to be inside, what can we do? So our next 4 interviews, we asked that question, we added that question, and we found 2 places that consistently all 4 of our participants were like, yeah, I'd go in here and use this. This would be okay. This outdoor location near the methadone clinic is best, but if I have to, you know, if it's inside, it'll get used, and this is a good location. So we did identify some of those indoor locations and we're able to find a solution. So, you know, if we find that we can't do outdoor, indoor is potentially okay. So ultimately, our macro and micro level evaluations provided something unique. So it was really helpful to kind of do that two-step process. It gave us different kinds of information, some specific to this context. And I imagine as we get into more detail and we're doing this at our other sites, this is gonna vary. This context, the micro level environment evaluations are going to provide some different insights at each of our locations. And then the iterative process really allowed for ongoing exploration and ideation to make sure the program is feasible, but it's also integrating this community perspective, and it's anonymous. So people that are in the community with lived experience are feeling comfortable presenting this information. So we are in the process of starting to gather our implementation team and bring them together and start talking about building that minimum viable product at this site. We're close to that stage at another one of our sites, and so we're kind of getting there. So those are our next steps. Again, this is only one site kind of presenting this information, and I want to note that modifications to these methods may be needed to appropriately address different topics. We're trying to build a vending machine, which can be inside, can be outside. There's factors that are very different with other things, but I have a friend who works in clinical decision support tools for providers. And I was asking her about this. I was like, does environment impact your work? And she said, yeah, it does actually. Where the computer is located in the room and how it's laid out actually has a big impact on whether people click the buttons or go forward, or there's some physical environment components that we may not even consider. And so making sure that that becomes part of context when we're thinking about that, when we're building our programs, when we're implementing our programs, I think is really important and needs to be something that we start to engage a little more systematically in the way that we're doing our work. So also, I want to note that we do have limited representation in this cohort, and so we are expanding to make sure that we get some additional feedback on these pieces. And I have a huge team of people that have all contributed greatly, including Jordan, who gave me some advice on how to build these interviews. I got lots of support from him on that phase as well. And so I'm looking forward to hearing about his project and shifting the slides over. I'll stop sharing now, Jordan, so you can share your slides. And shifting over to you now. Do you have what you need there?
I believe so. I am. You see my slides, Nikki?
Yes, they look great, Jordan.
Excellent. Thank you very much. Great. Well, that was an outstanding presentation, really exciting, and I'm excited to follow that with a little bit of related kind of a project here where we're also using citizen scientists and we're doing a type of walk audit here. And so I want to talk a little bit about our experience in this project and engaging community members in these walk audits. And I'll tell you first a little bit about why we did the walk audits, what this project was about, and then how the approach that we use to engage the community. Excellent. So this was kind of this walk audit project was kind of a sub project that was really part of this bigger study where we're investigating this zero fare bus policy in Kansas City that made it free for everyone to ride the bus. So back in 2019, Kansas City adopted this monumental policy. And again, anyone can ride the bus for free at any time. And we are pursuing a health evaluation of this policy, where we're looking at how this zero fare free bus policy may impact health. Here's kind of our conceptual model. We're specifically looking at whether residents in our city are experiencing increases in physical activity, which we know riding the bus can have direct impacts on, as well as all kinds of other health benefits like better access to healthy eating, access to health services, decreased economic barriers to transportation, just generally increased mobility, increased access to jobs. And then some of our end outcome variables are things like body mass index, blood glucose, and blood pressure. So we're trying to look at this fairly comprehensive model of how free bus service, free bus transit may impact health. And get these slides. And so as part of what we're looking at here, to understand the health impacts of transit and zero fare transit on health, we really wanted to gain a better understanding also of barriers to using public transit within this context in our city. We know that based on prior evidence, there's a lot of barriers to riding transit. These are multifaceted. Things like culture, personal circumstances, access to transit, neighborhood environment factors can all play an important role. We've been conducting focus groups with community residents here to learn more about each of these types of barriers, each of these sources. But then our walk audit project is really specifically about this last one, looking at neighborhood conditions. So again, our walk audit sub project here is investigating how different neighborhood environment factors that are directly around the bus stops in our community might relate to being able to access those bus stops and use public transit. So someone who may be someone's ability to experience health benefits, increased mobility, increased access to jobs, it may be dependent somewhat on the neighborhood conditions and their access to those bus stops. At least that's our kind of our theory here. So we're looking at things like the pedestrian and walking infrastructure around those bus stops, the availability and quality of amenities at those bus stops, and other elements related to safety and being able to access. So one thing I'll point out that was a little unique for us here is our research study, since this is part of this broader study, we're really needing to use these audit data for the research purpose to do this investigation, to learn how specific neighborhood environment factors relate to bus use. So we do know already we know which bus stops are used more often than others. We get that from the ridership data that's collected on an ongoing basis by our transit agency. We also know which bus stops have experienced an increase in ridership from before to after the zero fare policy was adopted. And so this is just a mock-up of a table that is intended to show just a few examples of the types of research questions that we're hoping to answer with these data. So how are some of these different neighborhood factors related to the variation we see across use of the different bus stops? Are the bus stops that are more likely to be used, or hypothesizing basically that bus stops with better pedestrian infrastructure, better safety, and more amenities will be more used more than other bus stops, and also be more likely to have experienced an increase in use after the start of the policy. And so we considered several factors when we're designing our data collection approach for these audit data. We really wanted for the data for these research purposes, as I mentioned, but we really wanted to collect them in a way that would support community engagement. And so community engagement has been important to us in all aspects of this project. The transit agency here is considering whether or not to continue this zero fare policy. They're also considering how to improve their transit system in our community. And so these conversations really need community involvement. And if we can support that, that's one of our goals here. And what we've seen, or what I've seen in projects that use these types of walk audits for research purposes, it's typically that the walk audits are conducted by research staff. That's usually easiest. Train your research staff to go out and collect these audits, and then use them for your associational investigations. On the other hand, there's been plenty of projects that have engaged community members to conduct these types of audits, but it's been done less so often where the data really lend themselves to investigational research, like testing the kinds of associations that we're interested in. So in some sense, two goals here of collecting these data for research, but also in a way that engaged the community. These two goals weren't entirely aligned. So we tried to use this balanced approach where we could kind of support both goals. And I felt like that was something a little unique than what I had seen before. And it was one of the main reasons I wanted to share. more about this project here. Um, so similar to Dr. Wagner's project that she just presented on, our objectives here aligned really well with the Our Voice approach of supporting discovery, discussion, activation, and community change. I think we aligned almost perfectly with these goals, this framework. We did not use the Our Voice app in our particular project, though, but generally fit this same framework. And really main reason we didn't use that actual Our Voice app is because our project has some specific or unique needs here, mainly being that we wanted to use a research-based audit tool, at least as our starting point, and collect fairly detailed information in our audits around these areas. It doesn't mean that you can't integrate this approach with Our Voice, and I also still think that it's highly aligned due to just following the same general framework. We were aware of Our Voice when we designed this project, but weren't really focusing on sticking within those boundaries. But it just ended up that the project is very highly aligned with that framework. A key takeaway for me here is that this Our Voice framework can be applied in various ways. It's quite flexible. This idea of the discover, discuss, activate, change fits really well within other models like user-centered design, as Dr. Wagner mentioned before. So like with Our Voice, we refer to our community member participants as citizen scientists. We engage these citizen scientists throughout the development and dissemination process. They informed the content of the audit tool, even though we started from a research-based tool that I'll mention more about in a minute. We trained and certified the scientists to conduct the audits, and engage the scientists to participate in the dissemination and advocacy after collecting the audits. And this is the pieces I'm going to get into more details here now. So here's kind of our approach. We recruited these citizen scientists through this wonderful community partner here. It's Kansas City's Center for Neighborhoods. It's a local neighborhood advocacy organization that has long-standing, strong relationships with the local neighborhood associations in the most disadvantaged areas of our city. And so they were so well established. We were able to recruit most of our citizen scientists through them. A lot of them are community members. Some of them already had some experience with being like kind of neighborhood champions. Some of them were naturally sort of advocates, and some of them just wanted to participate and learn more. And there were, as always, a few people that wanted to do this for the money. And I was really excited to see all of these people coming from different places, really engaging in this project. We were able to recruit 36 community members. Our goal was between 20 and 30, so we were really happy with 36. That was almost, even more than we thought we could handle, but it worked out perfectly. And the scientists naturally fell into two groups that we kind of, or cohorts that we moved throughout the process, where one group was more of like the group that wanted to meet during the daytime. The other group had evening availability, wanted to meet in the evenings. So we split it into about two groups of about 18 or so people, not exactly, but about half and half. And each group met 4 times throughout this process. So our first meeting, our kickoff meeting, really focused on planning, reviewing the audit tool, discussing, refining, and then also some initial training. The second meeting occurred shortly after that and involved certification, some additional training and some certification where we're out in the field for most of this time, walking in the environment, starting out doing audits together, and then transitioning to the citizen scientists doing the audits, and then us checking the accuracy afterwards and certifying them. Unless we have any concerns, then we continue to work with them until we're certain that they are understanding the process, that the instructions are clear. Most of the refinements that we made through this process were really just clarity based, making instructions as clear as possible, making wording things clear, and resolving any kinds of questions that come up along the way. The group asked a lot of good questions, and we were able to just add little clarifying pieces so that these questions could get answered in a clear and consistent manner. Once after the certification meeting, then the citizen scientists spent about 2 months completing these audits on their own while communicating directly with the project staff. And so the 2-month period is about how long it took for all of these audits to get completed. I'll show you the large scope of how many audits we just did in just a minute. And then after the audits were completed, we reconvened these groups, discussed the findings, did some reflections, and then moved to our celebration event. So we did select this research-based audit tool, which comes out of San Diego, and I believe the author might be on this call, Dr. Salas. And so it's the microscale audit of pedestrian streetscapes. I will say we adapted the tool a bit, mainly to try to simplify some things. There's different versions of the maps. There's brief and mini versions. We just took the items that were most important to our research, but simplified some of them and reduced some weren't as important because we wanted to really keep the tool fairly, brief and appropriate for use with community members, which meant, we didn't want it to be as extensive as the tool that you would use if your research staff were conducting these audits. Our tool ended up including a section for street blocks or street segments, the intersections, and then also bus stops. And the amenities around the bus stop. So here you can see some of the constructs that were included. So here's the scope of our audits here. We focused on 10 specific zip codes in the central part of our city, and then we selected a subset of the bus stops in those zip codes to be audited. We mapped out walking routes around each of the bus stops. The walking routes went either towards residential area or commercial areas. So each bus stop had a mix of those different types of routes. The routes were about 4 blocks long. So we're just kind of auditing a proportion of the areas around each of these bus stops. And one thing I'll point out here is that because we needed this data for our research, this ended up being a massive scope of work. It required an approximate 300 total hours of citizen scientist time. And really the primary way we were able to accomplish this scope of research with this group of 36 people was by being extremely flexible in the number of audits that the citizen scientists were asked to complete. So we didn't put any hard requirements on this. We assigned each scientist one audit at a time. Some people loved it and kept coming back for more. Some people did one and they were kind of good after that. So we had a mix, and we just had this nice distribution where we had all mixes of people as far as how much they wanted to contribute here. And it worked out just fine. We were totally fine with people who only wanted one. We kept engaging them in all of the meetings. They were still an important part of the group. And we were really happy for the people who did 10 or 15, things like that. And so that part, I think, really helped make it successful, that we set it up like that from the very beginning and didn't overwhelm anyone too much right at first. So after the audits were completed, we had this reflection meeting where we facilitated these semi-structured discussions with each group of citizen scientists. Discussions focused on the scientists' experiences while conducting the audits, their perceptions of the neighborhood conditions in their communities that they experienced while they were out there doing these audits, and their preferences on how to share the information, what to do with this information. And the content of these discussions was then compiled into kind of a report of findings that's really framed from the scientist perspective. And so one section of the report focuses on these key findings that were prioritized by the scientists that were uncovered in these structured discussions. And so here's a few examples of things the scientists wanted to highlight. In the top left, you'll see 29% of the walking routes had poor quality sidewalks. 77% of the intersections that were on blocks that specifically had a bus stop had no crosswalks. And then on the bottom here, what you'll see is that 18% of all of the bus stops didn't have any kind of lighting, not even street lighting, and 8% did not even have a sidewalk to get to the bus stop. So here's some of the things that were highlighted and noted by the scientists when they were out walking in the the report that we put together also encompasses the reflections and recommendations that were shared by the scientists. So here's where some of the qualitative work comes in more here. In these reflections meeting, the citizen scientists had so many insightful things to share. And to me, this was really the most impactful piece of this project was these discussions that we had where we're really talking through the information, what they think of the information, how they want to share, what are their viewpoints on this. It was really neat to see different viewpoints that were reflected by the citizen scientists coming together from different neighborhoods, different backgrounds, different missions, and engaging together. So here's some of the reflections that you can see here. One of my main takeaways from these discussions and these reflections coming from the citizen scientists is that the community members were extremely solution oriented, more than I could have possibly imagined. They did not expect easy solutions, which I was concerned at some points, are they really going to get frustrated because we can't change something? And that's not what happened at all. They really recognized through this whole process that solutions are going to require this continued momentum and this and collective impact. And they just kept saying how they want to keep working towards this and keep learning more about how they can keep working towards this continued momentum and collective impact. And I would just say, even myself, I learned so much through this process. It was just so fun for me. The citizen scientists, their desires, their aspirations, and their reflections that they shared in these meetings were also framed into recommendations that were included in the report. These recommendations are for public officials, community leaders, and community members. And again, this is all just additional content that came from these wonderful semi-structured qualitative discussions with each of these groups of citizen scientists. A few things I'll emphasize here, or that were emphasized by the citizen scientists, some really powerful viewpoints that I really felt came across in their comments and their ideas, like wanting to connect pedestrian infrastructure both with transit. Obviously, that was one of the purposes of the project, but also with housing opportunities, housing programs, thinking more broadly about this. A strong desire to really organize grassroots efforts to support neighborhood maintenance, knowing that we can't just complain or expect, the city to do everything. Yes, we need to advocate for that, but there's also other things that can be done. Several of the citizen scientists were already doing grassroots efforts or really, really wanting to do more there, which was just super empowering to hear. Another one is just shifting the culture away from dangerous driving one person at a time. We had a lot of citizen scientists who really felt strongly about public transit, and so because of the importance of public transit in their communities. And in addition to just pedestrian safety, they felt that from the public transit point of view, that really there's just this dire need to shift the culture away from dangerous driving more onto the communities that are safe to be out walking in, and really focusing on doing that really one person at a time, and not giving up. And so this is something that came from the citizens as well. And lastly, just kind of acknowledging their desire to really better their communities more holistically, focusing on social capital and building relationships in communities, and how all of this kind of fits in and can fit together. Um, Last couple things I'll mention that were in the report is we created these maps. We really hope that these would be a decision tool for decision making and advocacy. These really point to the specific areas that someone can quickly look at and see where improvement projects could be focused. So we've got, a red shows poor quality routes for sidewalks or poor quality crossings near the bus stops, or poor quality bus stops based on the availability of amenities there, versus the color red shows where those attributes are more faithful and maybe need of improvement. So we did that for each zip code that was audited, and that's included in the report. We are making the full data set available. We tried to really synthesize and keep things fairly straightforward for decision-making purposes and advocacy purposes, but for anyone who wants the more detailed data in our community, we not only make it available, we can support the use of that. And that was just important to us, just feeling that these data really truly belong to the community, that viewpoint in this work. And then lastly, we just so happens that this evening is when our celebration event is happening. So I'll be headed there later this afternoon. The citizen scientists are celebrating the release of their report. And really what we did is we worked with the scientists to organize this event, create invitations that then they shared with their peers, others in their community leaders. We tried really hard to invite some decision makers, officials, and one really exciting thing is we have RSVPs from several elected members of the city council and staff from the city public works department who are in charge of doing these infrastructure projects, and also several leaders from equity-focused community organizations in our city. So I'm really excited about getting these key city leaders, decision makers together with these citizen scientists. The citizen scientists are going to kind of give a background on the project. We're going to disseminate the report, share copies with everyone. Going to focus on this moderated panel where the citizen scientists are going to answer some questions that they designed, really to share their reflections and what they learned through this process, and where they want, how they want to contribute. I'm anticipating, this just being a very positive and uplifting event. I think everyone here is coming from a really positive place, and just really eager to, engage in these conversations together. And then we also are going to have a advocacy presentation from the local bike ped organization at this meeting. And there's a reception and discussion and Q&A where we're really hoping to engage some of these attending decision makers in these broader conversations as well, hoping we can make some additional connections, carry some of this momentum. So a few considerations here. I'm going to skip the summary because that's already been covered. Some of our lessons learned, that it took us more resources to conduct the work with citizen scientists than it did to just use research staff. But again, that we budgeted that in the grant. That was what we wanted to do. And so we were able to make that happen. Just a consideration, though, is it requires more resources. Even though we simplified a lot of the tools and trainings, we needed to do more there. So when next time we do this, we're going to make even more refinements for simplification, making things as easy as possible. The audits themselves can be complex because we are wanting quite a bit of quantitative information. If you could make a way to pre-fill out information or do it electronically, you could save a lot of time there. And again, embracing the champions, I thought was really important. One thing that was hard for us was to move this all quickly. It was really hard for us to take the audit data and turn it around into this been yet been able to look at radar reliability and things like that. But we didn't want to pause too long while we have the citizen scientists engaged. So we've just kept moving forward with all of the engagement aspects. And then after tonight, after we have our celebration event, then we'll have more time to dig into the research data and do more quality assurance. A few limitations, we've kind of generally based our approach on some previous research, but there are entire advocacy curriculums out there. So if you're interested in doing this work, there are established curriculums that have been evaluated. We didn't do a formal evaluation of our engagement efforts in this project, so that's another limitation to consider. Although we have, we're sharing this information and doing some engagement, we're not going to know exactly what happens with that a year from now. We want to and plan to stay engaged in conversations, but it's hard to do a formal evaluation of that. That's something. I want to just acknowledge our strong team here. This is a massive team of investigators who contributed to this with a lot of local partners, community partners, and funding from both NIH and the Environmental Protections Agency. And I'll leave you with a few pictures while I open this up for questions. And I know there was questions for Nikki as well, so thank you for bearing with me and holding your questions till the end. And maybe I'll turn it over to you, Nicole.
That sounds great. Thank you so much, Jordan and Nikki. Wow. Just outstanding presentations and work. I'm already thinking about how I can potentially use our voice in some of my my projects. So just a couple of housekeeping pieces before I get into questions. Since we have a relatively smaller group, I encourage everyone, if you're able to, just stay on the Zoom as we kind of move through all the questions that you posed. No need to, register for the consultation period. We'll all just stay on as a group. And Carrie is flashing here. If you do have to go before the not top of the hour, the half of the hour, we do ask that you complete this 1-minute evaluation of our session here today. But I'll start us off with a question. Nikki, this was posed to you, but I think Jordan, you're also welcome to chime in about it. We're curious about how you assessed engagement of your citizen scientists. I think both their kind of peer-based engagement and then also their engagement with the research team. I'm just curious if the process itself changed sort of engagement over time and just your assessment methods for engagement.
Yeah, so for my project, I think the assessment of engagement is going to come a little bit later on, where we have our citizen scientist that's more engaged in the actual implementation team and connecting on that front. We did these as interviews when we initially did our walking audits and got their feedback and got their pictures and got their take. And what I did was asked at the end of the session, tell me what should I share with our team? You pick the picture, bring your input to that piece. But in terms of evaluating engagement, we didn't do it at that level. We did get a lot of feedback. Thank you so much for doing this. Thank you for letting me bring my voice to the table. We did hear a lot of that feedback in that discussion. But since they weren't involved in kind of that back and forth discussion with the organization team initially, where we were working out feasibility issues, we're waiting to do engagement until they're more integrated into those discussions. And I think Borska, I think you asked that we're looking at we have a colleague that's building a new co-creation tool. And so we're going to use that survey item as well as interviews on that piece.
That's fantastic. Thank you, Nikki, for sharing. Jordan, how about for you? Similar approach, or do you assess engagement a little bit earlier on?
Yeah. So we haven't been really evaluating our engagement. So I will admit there's not much science behind our engagement process. The science is more of the broader research and where this piece fits in. So we've thought about that, and I would say it was that kind of added like extra elements of resources needed and things that we just didn't prioritize. Most of what we have been looking at. Of course, I mean, we have like attendance at the meetings. We know how many audits each person did. But other than that, it's mainly been qualitative. We have a lot of, in our meetings, it's a lot of qualitative work where we are capturing, the feedback that we're getting from folks. Yeah, we didn't even do like an evaluation survey or anything like that. It's not too late, we could always do that, send something to the scientists. We did do some qualitative or some surveys based in part of the input gathering phase where we're trying to kind of understand what findings they want to highlight from this work. We had the qualitative discussions, but then afterwards, the citizen scientists received a survey that asks some additional things like where would you prioritize these different findings or things like that. We didn't get a high response from the survey though. Really, it came down to the qualitative input. Just wonderful high participation in these qualitative discussions is where I think our strength was.
Excellent. Thank you, Jordan. I'm going to riff off of that question. And I'm now curious, do you do any, or do you anticipate doing any kind of assessment of the citizen scientists as a network? Like, do they continue to interact together? Are they kind of forming subgroups to kind of continue work on their own in their neighborhoods? Thoughts about that?
Well, I think those are great ideas. Yeah, I mean, I can't say we have anything planned. Um, and part of me wonders, how much are we going to see there? But I think it's critical to better understand those things. There was also a comment that's a little bit related, or a question about how do you engage community members who maybe don't naturally self-select into things like this. So a lot of our people, citizen scientists, were already engaged, and that's why they self-selected. Not all of them, though. Some of them wanted money. Some of them were in between jobs and they had time. There was all kinds of factors that motivated people, but generally, yeah, there was self-selection for people who wanted to share their voice about their community. And so I think to engage, more people to kind of who are maybe not to that stage, but you want to move them more to that stage. You probably need quite a different approach, where we kind of put a blast out there and took the first people who came to us, and we're just really grateful to engage with them. I think you would probably, spin that around and really target a specific type of community, work with specific community partners that provide access to those community members who aren't already serving as advocates in their community. Start earlier in the phases of advocacy, and that's where some of those existing advocacy training curriculums that exist around the built environment, could be used or pulled from. So it's a really, really important question, Lillian. So thanks for asking.
Thanks, Jordan, and thanks for taking a first stab at Lillian's question. Nikki, how about for you? You described a very different group of citizen scientists compared to Jordan. How are you sort of successful in identifying them, and other guidance for the kind of harder to engage populations?
Yeah, it's interesting because I'm having very different experiences at my sites. And what I'm finding is that, in Denver, we have a really strong network of organizations and resources that provide services to people who use substances, and they are connected to other people who use substances. So that snowball sampling is really effective with this cohort, because they let people know. We had an incentive that people were excited to receive. They were really interested in kind of, we want this resource, and so how do we help you, make sure that we can get it. And so we had a pretty good response rate, just kind of connecting with the resources that we had and the services that we provide in Denver. Up in Breckenridge, we have in Summit County, we have a limited number of services provided. There isn't a lot, they've got their public health department and they've got their health system that provides some social services, but they aren't as well connected. And so recruitment has been a real challenge in that community. And we're actually adapting some of our methods. We were using flyers, we were connecting with the services provided, and we've had less success. And part of it, I live close to Denver. I'm here, I can sit at the clinic, and so we have to engage a little bit more with the community in Breckenridge. And so we're using the resources that we have in the community, but we're also starting by using anonymous surveys. What I was hearing from people is, I was talking to a number of people who had been sober for a number of years. They didn't qualify for the study, but they were just kind of giving me input. They're like, here's where I don't go. So you can put it here. This is where I don't go. This is the advice on the best locations. But they were telling me, people are going to be nervous and not willing to admit that they use drugs. They're not going to tell you they use drugs. They think you're partnered with the public health department. They think you're going to, rat us out to the cops or something. They don't have that same connection with research. They don't have that same connection with the service providers. And so in that case, what we're doing, we're adapting, and we're gonna build an anonymous survey and see if people report on an anonymous survey where they think, and then try to use that as a way to identify people that are willing to go on walks and to provide some additional information. And so we are having to adapt our strategies based on the location. And I think particularly in communities that don't have substance use services, that's a real challenge, and having to find kind of some innovative solutions are important. And that's our approach right now.
Thank you, Nikki. Really helpful ideas there. I want to just take a moment. There's some additional questions here, but just in case anyone wants to unmute and share a question or a reaction or reflection right now, we do have some time.
Nicole, I really liked your question about, do you start with the community organizations, or this was for Nikki, or do you start with the community members, and how do you balance that? There could be certain parameters or boundaries within what can be accomplished, and how do you account for that, when you're working with community members? That's a really critical question, I think, in all of this work. So I think that's a great question.
Yeah, and actually one of the things I did with my work too, I thought, I started with the organization to figure out what's feasible, let's make sure that we're looking within what's feasible. And so we started with the organization from that perspective. And I think that may be true in a lot of cases, that, some things just are off the table and aren't even an option. So let's take those off the table. Let's not even start there. But one of the things I wanted to do was, well, let's figure that out and know that up front and make sure we focus in those areas. But I'm not going to put that on the table to start. I want to hear from the community first. What is the desire? What do they want? And I feel like that step is important. My really good partners that I had at my health system in Denver, they were on board with that, and they're like, yeah, let's not restrict this. Let's see what they say. And they've been really great at kind of adapting and working with us on that piece. But I think getting that perspective is important because, as we were talking to our providers, we were able to figure out some solutions. Outdoor was maybe not feasible, but actually we could potentially put a camera out there and that might cover that need. And you start thinking about things that you may not have considered before, and you don't even know to think about them unless you have that data. And so from my perspective, I think the community is where you need to start. And I think the organization feasibility is important, and having an understanding of that going in can help frame how you ask some of the questions. But I would encourage people to not start there. You can start there, you can have that knowledge, but don't limit your questions with your community to that, because you might lose something in that process.
Thanks, Nikki. I really, really appreciate that perspective. I was initially, concerned that if you opened up all possibilities to your citizen scientists, they would be so disappointed or frustrated with you that their ideas weren't actually listened to. But you raised some really good points about, well, even if they do, the ultimate decision makers might learn something and maybe more willing to problem solve about how to make those ideas work. So very, very helpful. Let me see, I'll look through some of our other questions here. Oh, this is one from Vorshika, a very pragmatic question. Um, Compensation. And I think, Jordan, you shared how you compensated on your really lovely recruitment flyer, but just curious how you sort of set rates and how you communicate that to your citizen scientists.
For me, it was all it's all segmented. It's all pieces that you get compensated for each piece. That's how we manage that, and that went over really well. The other thing that we experienced, and again, I think this is highly dependent upon who your citizen scientists are, where they're, but I don't even think we would have had to pay a lot of these people. We did pay them for coming to the meetings, but oftentimes they didn't even ask for their money. We always gave it to them, but it was clear that that's not why they were there. I think when they're conducting the audits, you really that. We probably didn't need to pay for the meetings, yet we did. We wanted to pay them for their involvement from the ethical standpoint, but for engaging in the meetings, it was necessary. Yeah, it was. We tried to make it as clear as possible up front and throughout the way. And we use at our institution, it's like a clean card that you just keep uploading money on. So it makes it really easy to just pay people in pieces. Some people earned, the minimum was probably around $100, and some people earned $600 or $700, I think.
Yeah, ours is similar just in the sense that each kind of step in the process that someone completed was a set amount of, $25 for completing these interviews, and we're gonna have similar for meetings.
Excellent. Thanks so much for that. Okay, let's see what other questions we have here. And again, our group is getting cozier. So again, if you feel inspired to unmute and share a question, you're welcome to. See. Oh, so this was one of my questions here in hearing Jordan about the amount of hours of walk audits that had been conducted by your citizen scientists. I was just curious if or how you engaged those with different needs, different visual, hearing, physical needs.
Yeah, I think that's really important and something that we didn't, do enough with. And I think we often, probably not just my research team, but I can only speak for myself, but fail in those areas. It's really hard to accommodate those things. We even try our best to do Spanish language. I can't say that every study we do has that, unfortunately. But and so yeah, I think that those are critical pieces that in our study it was mostly people self. We didn't encounter any unexpected things, but yeah, people kind of self. We did have people with some mobility considerations. We had all ages. We had some youth. We had some youth who were with their parents, some youth that were kind of with other youth. We had older adults, so it was the full spectrum. And one thing that we did to help with some of this gets at a little bit of your question is, some people really wanted to go out and do these audits by themselves, but we didn't want youth doing them by themselves, and we knew not everyone. So we really supported and encouraged the citizen scientists to engage with others. So sometimes there was people who knew each other. There were several families, like a mom, an aunt, and a daughter. That was one of our groups. We had a lot of situations like that where they're able to do these audits together. So they're not out there there's not a kid out there by themselves, or they can support one another. Just being super flexible and trying to, play on some of those synergies, really encouraging people who want to work together to work together. You know, you don't have to do completely independent stuff. Yeah, I think, there's a lot more that we can do to be more inclusive for sure.
Thanks, Jordan. Nikki, how about for you?
Sorry, I got my kid just texted me and I got a little distracted when you asked, can you repeat your question for me?
Sure. Just your strategies for engaging, or for just kind of being mindful of inclusiveness and who your citizen scientists are. Do they have, visual or hearing impairments, mobility needs, things like that, just with understanding that these kind of walk audits are part of the process?
Yeah, and for me, it was actually weather. That was more of the issue coming in. So we had, we had been doing, we did it earlier in the, like in Summit County, we did a couple that were in, before the season started. Now we're in winter. And so that's going to be a very different kind of walking on it, but it also gives that perspective of what it's going to be like in this temperature. And so we use more car-based driving to locations when we were there. At Denver Health, it was more walk-based, and we had, we didn't have any issues with the participants who wanted to participate, but did have some kind of structured, we have these top 2 locations we're going to go to, and we talked about it before and made sure that it was amenable. So that was kind of how we approached it. We didn't, we would have adapted as needed in the situation, but just didn't run into any circumstances where people weren't comfortable or didn't have capabilities to walk the environment. So it didn't pose a challenge, but we would have adapted in some way to address that, and really thinking about getting to locations in a certain way, choosing a smaller footprint. We didn't have requirements on the footprint on where they walked. And so some of us walked the whole campus, some walked a shorter area. And so we have some flexibility in where we go, and would be able to do that if necessary with people.
Great. That's really helpful, Nikki. In San Diego, we're now having to think about weather. I don't know if you've been watching the news reports, but we have these atmospheric rivers that are now happening. We had some last week, and I think we're in for like 6 days of rain. So weather is now something that we need to be very conscious of. So I think we've covered all of the questions, and maybe there's one remaining here. And Jordan, I think you sort of addressed it when you talked about how families would come together and youth were involved in your as citizen scientists. Nikki, how about for you? In thinking about engaging young adults, and I know substance using, members might be a little bit challenging. There may be some ethical concerns as well, but any thoughts on how you might use this approach for young adults, 15 to 24?
Yeah, I actually did think about it a little bit, because young adults were originally kind of the target population I was looking at. I had done some interviews with young adults who were 18 to 25, 18 was my cutoff at that stage. The requirements in terms of the research perspective with young adults do require, kind of that additional layer of parents' consent. There is some benefit with people if they're receiving substance use services, they can consent for those on their own. So that does give you a little bit more flexibility on that front. If they don't want their parents to know they're using substances, that would allow them to consent for it. There is some privacy restrictions on that front. So there is some opportunities to do that. I think it would look a little bit different in that population for sure. Although I would say that the young adults that I talked to gave similar perspectives to the people that I was walking with that were a little bit older. So we were on the same camp. It was people recruited in a similar way that I had worked with, and they said some of the exact locations that other people were saying and were showing on the map. And so I actually don't think it would differ that dramatically in that cohort. I think maybe the under 18 might have a little bit different perspective, but I think that would likely be a different intervention maybe too. So that might need to include some different features. So I think, there's other considerations as well.
Thanks, Nikki. Really good thoughts. Borshika, do you want to share your question?
Thank you so much. I just wanted to also verbally say how wonderful this session was, and thank you to both of you for doing it. My question is getting now really down to the nitty-gritty, and since it's almost the end of the time, I thought I would bring it up. Nicole and I have been already side conversing about how we could incorporate these methods into our own work, actually coming up proposals. So Nikki, you have actually used the software and collaborated with Abby's team on this. How did you kind of set up the collaboration? What was the kind of the parameters of how much you are kind of doing the parts and how much their team set up things for you?
Yeah, so it was great. They were great. They've been great to work with, and we continue to partner. And I've, we're, kind of connected in the Our Voice network, and there's a international group. So it's been really great kind of connecting on that front. But really how it works, I kind of reached out to them. We built a budget that was appropriate for them to build it. So they build a specific use of that tool. And that you build your question that you want to ask and can kind of tweak it based on what you need for your specific project. And then, you kind of have a code that participants can use to log into that system. The data is stored at Stanford, and then you get a login information to extract it for use as you need it. So that you build essentially a, kind of a contract for them to build what the tool that you're using. And then I think within the agreement, where we'll definitely, and I just like working with Dr. King, so she'll definitely be contributing to some of the articles that we're writing, and when we're talking about Our Voice, their contribution and making sure that we describe Our Voice appropriately and all of that stuff is kind of part of that agreement. So those are kind of the logistics and pieces, but it's been that was the process. It starts kind of with what's the expectation, what are you needing, and does it fit within this, and what's our budget to do this.
And I'll just add, I think, my experiences with them, it's a pretty robust effort and group there. They've got some solid resources behind this. There's a team member who's, either full or has a large amount of time to direct and manage all of the Our Voice things. So, and she'll meet with you and consult with you and do your budget and all of that. And they've done it, I think, for so many projects now that it's like a well-oiled machine. I worked with them, I think, for a grant application a couple of years ago, and they were very well versed in working with investigators at that stage, at that application development stage, and doing a budget, and really knew what they were doing and had the resources to support that stage of the work. So I was really impressed with the other capacity there.
That's really helpful. Thank you so much, Jordan and Nikki. We received another question here. I'm not sure it was available to everybody, but I think it's a question maybe for Nikki in particular. Have you tried to put your vending machines around homeless encampments?
So with our project, we're kind of doing it in collaboration with our partners and deciding where it goes. And so we'll see. We haven't made those final decisions at any of our sites yet. There are definitely some located at homeless encampments. That is a location that has them. I know housing is one location. We're considering actually doing kiosks in Summit County and some of the housing that they do for seasonal workers that come up for the ski season. And so we're thinking about putting one in that kind of housing area. So it's not the same as a homeless encampment, but, similar in the sense that, there's kind of these categories that we're finding. It's the jails and, correctional facilities and police stations, fire stations. And then there's places like health systems, substance use treatment services, there's harm reduction agencies, there's libraries are a common place where they're putting, at least the naloxone's available. They're considering vending machines there. That's a commonplace. It's kind of across the board. Everybody's doing it kind of differently right now because nobody knows the best way to do it right at the moment. So it's being done all across the board and very differently in every location based on, the local context. So, yeah.